Hello everyone, my name is Nicole Barnes and I will be talking to you today about how effective medication-assisted treatment in preventing and or decreasing overdoses. Drug abuse has increased since the 1990s due to the prescription of opioids as painkillers. More than 70,000 individuals succumbed to drug overdose in 2017. MAT combines medication and behavioral interventions, which increases mortality, remission, and treatment retention. Drug overdose is also linked to the declining life expectancy rate in the U.S. Drug overdoses as a health crisis. Drug overdose deaths attracted public attention from 2013 due to synthetic opioids. Mortality related to the synthetic opioids has increased by 45% between 2016 and 2017. The effects of drug overdoses extend beyond the immediate effects it causes to the users. For instance, opioid overdose causes HIV and hepatitis C infections. Besides, hospitalization costs increase to more than $700 million annually. Medication for drug overdose. MAT focuses on managing withdrawal symptoms and controlling or managing the compulsive use of a drug. MAT reduces the mortality rates and has high medication treatment rates. The FDA has approved extended-release Naltrexone, methadone, and buprenorphine for treating overdose, just to name a few. MAT reduces drug abuse, substance use disorders, and social consequences such as crime. Besides, patient characteristics such as mental well-being determine the effectiveness of MAT at certain periods. Methadone is a MAT with a synthetic and lasting opioid agonist. Methadone activates mu-opioid receptors using the same mechanisms used by illegal or prescription opioids. The medication occupies mu-opioid receptors to weaken withdrawal symptoms during treatment. At therapeutic doses, the medication weakens elated highs caused by shorter-acting opioids. As an agonist medication, patients can commence treatment without undergoing opioid withdrawal. However, the medication sustains the physical dependence of a person suffering from substance use disorders and tolerance. For this reason, the drug can cause withdrawal symptoms when patient stops the medication. That's why it is so important to speak with your healthcare provider or your prescriber who is giving you the methadone, so it won't cause you so much, or you won't experience that chronic amount of withdrawal symptoms. So it is not a good idea to stop taking your MAT treatment on your own. Unlike other drugs such as heroin, methadone does not prevent patients from engaging in other activities such as employment. Most people attend MAT because they do want to keep their jobs. They do want to establish a healthy lifestyle. And with treatment like MAT, it affords them the opportunity to still be a functional and contributing citizen of their community. Buprenorphine. Buprenorphine is a partial opioid agonist and antagonist of the kappa opioid receptor. For this reason, it does not substitute for additional opioids existing in the mu receptor. The drug reduces the withdrawal effects of opioid overdose and minimizes the rewarding effects of patients using opioids and buprenorphine. The medications has minimal effects on respiratory depression. Buprenorphine minimizes the risk of overdose compared to methadone. Slow dissociation kinetics allows the drug to have mild withdrawal symptoms. In this case, the therapeutic dose is achieved in a short period of time. However, buprenorphine sustains physical dependence and tolerance. Extended release naltrexone. Naltrexone is full antagonist MAT. Naltrexone affects the mu opioid receptor and blocks the elated and analgesic impact of all opioids. Naltrexone does not induce physical dependence. Besides, the medication does not cause the rewarding impact of the opioid. Unlike other medications, naltrexone is not an opioid. As an injection, some people choose to use Vivitrol, which is the injection form of naltrexone. From my experience, a lot of patients will prefer the injection over the naltrexone pill because that leaves them to not have to worry about the stress or worry about taking the pill when they can just come get a monthly injection and be covered for the rest of the month or for the next 30 to 31 days. Benefits of methadone and buprenorphine. It reduces opioid use. It improves socialization. It decreases HIV and hepatitis C infections and provides a better quality of life. Effectiveness of MAT. Long-term medication with methadone or buprenorphine reduces mortality and morbidity. Treatment with agonist medication reduces the mortality rate by approximately 50% among individuals with opioid use disorders. MAT increases the quality of life among patients. Medication reduces incidence of drug overdose. The health status of patients increased after 6 months of MAT. Patients also record a decline in pain concerns following the use of medication. MAT is also associated with the reduction in the use of alcohol and other substance use disorders. Community-based programs. The programs incorporate drug users into the community care setting. In Utah, abstinence from drug overdose increased by 84% due to the programs. Over 3 years, the CDC recorded a 12% decline in drug overdose. The programs lead to improved outcomes, reduced expenditure, and reduced patient admissions. MAT in the prison setting. Many patients do not continue with MAT after incarceration. Lack of treatment increases the mortality rate after incarceration. Notably, 63% of prisoners have a record of substance use. Lack of treatment threatens the welfare of the prisoners, which ends up causing us more costs in society because then we have to afford the prisoners more care, and more treatment equals more dollars. The prison setting shows the effects of partial MAT treatment. Notably, after incarceration, patients engage in aggressive drug overdose. MAT does not fulfill its purpose if patients fail to take the medication in the long term. Besides, the lack of treatment shows loopholes within the justice treatment in the treatment of drug overdoses. So typically, when someone is on a MAT, whether it be out in the community or whether it be in a prison, just MAT alone does not typically fulfill its purpose. It is highly recommended and encouraged that MAT is used in conjunction with some other therapy modality, such as outpatient, intensive outpatient, using cognitive behavioral therapies, or motivational interviewing, or any other therapies that you think will benefit the patient according to their need. Barriers to MAT. Stigmatization of patients and healthcare workers providing medication. Legal barriers that limit the prescription of medication. Knowledge gap among healthcare workers. I will tell you, stigmatization of patients and healthcare workers is huge when it comes to MAT. And so I've heard through many different patients, it's also stigmatized in certain self-help groups, more specifically in Narcotics Anonymous. A lot of my patients have come back to report to me that they don't feel very welcome in those self-help groups because they are using MAT. MAT is effective in preventing and decreasing overdoses. Community-based programs led to 84% abstinence rates. Besides, treatment with methadone or buprenorphine led to a 32% reduction in severe opioid-related care within 3 months. Patients also recorded an increase in the quality of life. Thank you for listening.